And they published a paper in the New England Journal of Medicine, I think the late 2000s, that really showed that people who get care in their home community from someone who attended the ECHO program have better outcomes than the ones who travel all the way down to Albuquerque to see the specialist. So my name is Wiplove Lamba. I'm a psychiatrist who mainly works with people who use drugs, and sometimes I do therapy, and I sometimes am part of education stuff, workshops, programs like that on training healthcare providers.
Absolutely. And I'm Jean-Paul Michael. I am a community case manager, and I work for an inner city hospital.
Yeah, and you also do a lot of education material. I think one of your official titles is harm reduction educator.
I believe it is, yes.
Yeah, and so 5 or 6 years ago, JP and I got involved with ECHO addiction medicine psychosocial interventions run through CAMH and Unity Health, which back then was called St. Michael's Hospital. And today we're going to share what the magic of ECHO is. So just give a bit of background so that you know what it is. It's not that echocardiogram. It's not that echolocation that bats do when they're figuring out where people are. It's an education module that started out in New Mexico and it spread to the world. And so we're going to share what that is. We may talk a bit about my experience on it, but I think the big thing for today is that JP at that time, your main title was a peer support worker. You primarily identified as someone with lived experience, at least in the hospital setting. Now you do so much more, although I still believe your role then was invaluable. And it was also invaluable in our education modules that we put together. And I'm convinced that the quality, the product, the impact were infinitely better because you were a part of the core team. Does that sound like reasonable for today's session?
That sounds like a good expectation, and thank you for the compliment there.
Wait, what compliment?
Well, saying I was an invaluable member of the team, that's nice to hear.
Oh, I guess you're right. A compliment can be authentic, right? Because I was like, oh, what do you mean? I'm just describing how it was, So ECHO is a hub and spoke education module a hub and spoke education model that was developed out of New Mexico by Sanjeev Arora. And Dr. Arora was a hepatologist, and you may or may not know this, but New Mexico has the most rural areas per capita in the States. And so what does that mean? When you have a center hub of excellence, nobody's nearby. They have to travel several hours to come in, all that kind of stuff. And what he found was that this was before all the new treatments. Back then, people were dying of hepatitis C while they were on his wait list. And when they had to come in for treatment for what they have to do, they either had to come down and stay in Albuquerque, New Mexico for like 8 weeks, or they had to drive down 2 hours every day, then 2 hours back to get their IV treatment. And there came a point where his wait list was 8 months, 1 year long, and people were actually dying on that wait list. And him, just like anybody else, found it very upsetting. He set up this hub and spoke model, and he got it funded. I think it was GE that funded some of the early studies. He evaluated it and got it published. And what ECHO is, it's a hub and spoke model. We have this expert hub that's at the center. Mm-hmm. And his initial one had a psychiatrist, a hepatitis C doctor, or an internist hepatologist, and it had a pharmacist on that initial group of 3. And then they had spokes. So they found the docs or nurse practitioners that were referring the most patients. They reached out to them and found a way to get funding for them to attend. And then over the course of a year or two, and back then it was more open, so he used to text message them, he had emails with them and stuff. And they would learn it through every week. They would have a 20-minute talk and then an hour and a half where they would talk about complicated cases. And what they found was that, over the course of a year or two, all of the audience members developed that subspecialty skill set of assessing and treating hepatitis C. And they published a paper in the New England Journal of Medicine, I think the late 2000s, that really showed that people who get care in their home community from someone who attended the ECHO program have better outcomes than the ones who travel all the way down to Albuquerque to see the specialist, right? And so we were so fortunate that even though he's a clinician, even though he's an educator, he actually evaluated it, and it got published in that journal. And since then, they've expanded to so many other diseases, right? So we're talking chronic pain, addiction, HIV, global health. They've expanded to teachers, the jail system. They had this Hep C program where they trained peers in a jail in New Mexico on how to provide harm reduction supplies. And back then, there was something where I think only about 20 to 30% had Hep C or hepatitis B, I can't remember, when they entered jail. Okay. And about 99% had it when they left. And so by educating, they made it so that when you go to jail, you don't have to get hepatitis B or C, whichever one it was. And around 2014, 2015, the Ministry of Health in Ontario drank the Kool-Aid. I'd attended ECHO for Pain that was run through UHN and Queen's because I'd started St. Mike's. I had no idea how to assess and treat pain, and we couldn't get the pain service involved unless they were post-surgery, right? And so you'd have these patients, you'd be giving them methadone, buprenorphine, and how to assess and treat pain. So I attended that program for a while, and I really wanted to figure out how to do it for addiction. And so I reached out to Dr. Sturgiopoulos, who was the chief of psychiatry at that time. She gave me permission to go down to New Mexico, so I went there for a day or a 2-day immersive training, and I was just blown away by them over there. I got about a 30-minute meeting with Dr. Arora. He's like, look, you don't need funding. You can just do it. You just build it. They will come. He's like, we share protocols. We share everything with you. We share previous grants that we've had in order to get funding. And when I came back, I tried to set one up. And after a bit of time, some of the leaders at CAMH reached out to me, or maybe it was a partnership kind of thing, where they said, hey, we'll help you roll this out. And now it's been about 5 years running. Mm-hmm. When we did it, I pushed very hard to have someone with lived experience on our hub. I don't think you were there as a part of our first 5 or 6 sessions, because I had to find people that were volunteering to do it, and I think there was a manager at the detox that allowed it at that time, but I couldn't get other people involved. But once the funding came in, we were so lucky to get you involved. We had a nurse, we had a pharmacist, we had another addiction psychiatrist, we had a social worker. And then over the course of 4 or 5 years, using the CAMH scholarly education principles, we've rolled out this program. And I believe it's one of the best ways to get a real taste of what a profession could be and what a skill could be. It's almost like a taster of everything. And it's really based around didactic lectures. It's based around longitudinal case-based learning. It's all done sort of virtually through this hub and spoke model. It was like ready for COVID when it came. Yeah. And it's this force multiplier, right? Whereas me and you have an expert skill set, where we know if we're working on an inpatient team, there's a patient in hospital who's having a life-threatening medical condition, we know enough that we feel there's a better chance if we're involved that they'll stay for their medical care than if it was, say, an internist who had no addiction experience. Right? And by training everyone who attends in the audience, all of a sudden they have these philosophies and ideas, and it spreads.
Yep.
So that's the background of the ECHO. What I'm going to do in the description is I'm going to share like a 3-minute video that says what it is. I'll share a link to a couple of papers. I might add a couple of paragraphs, about our ECHO AMPI. I might even promote the next session because registration's coming up soon.
Promote away.
We're starting in a couple of weeks on the Monday the 23rd, I think. Good. And we're dealing with concurrent disorders, 8 sessions, hour and a half each, concurrent disorders, learn all the basics, present your tough cases, yay. But that's not why we're meeting today, is it, JP?
I don't think it is, but we're always good to promote the cause.
Well, if you have something that's doing good for others, whether you're intensively involved or not, you just want to help people in general, 100%. Right? The morbidity and mortality from addiction has just gone through the roof, and we need more teammates. We need 100%. More teammates. No more gatekeeping, if there ever has been gatekeeping in whatever. So the reason that we're doing this today, after this 50-minute intro, the reason we're doing this is because I believe we were the first ECHO in Canada. I believe, I might be wrong, I don't know, to have someone with lived experience as a part of our expert hub who is there for all the planning meetings, there for all the debriefings, there in terms of the curriculum design, right? You remember, we have all these sessions, you're like, should we include harm reduction? I'm like, no, we don't need to. You're like, come on, I think we should include harm reduction. Okay, I'll present it. Do you think you should be presenting it? We had all those dialogues. And because of the way CAMH is set up, they have such good infrastructure, they have such good operations teams. the product just kept getting better and better.
Yes.
The evals kept getting better and better. The attendance was better and better. And some people would stay for 2 or 3 cycles. And we evolved it so it wasn't like a 1-year, 24-week intensive. It was 3 parts where 1 part was engagement, 1 part was addiction medicine, and 1 part was complexity around concurrent disorders.
Yes. Yeah, absolutely.
So why don't I start asking you some questions?
Sure.
What was it like going from somebody who was dealing with an addiction to going through the point where you're joining an addiction medicine team in hospital working with patients to provide medical care?
Sure. And that, I guess that's a great question. It kind of predates my ECHO involvement. Yeah, I mean, it's turning a I guess you know, not to give too much of the backstory, but I, you know, was somebody who had navigated a lot of healthcare at that point.
Yeah.
8 different ICU visits by that point, personally.
You know, you never told me any of that stuff, eh? I had no idea how unwell you were before.
Right. And I don't, you know, you know, wearing that on your sleeve is not something you really want to do. And it's kind of a bit of an uncomfortable dance a little bit when you're, you know, dealing with the hospital that you were.
But I mean, it helps me understand because you were so good with the patients that we saw. They would swear at me. They would yell at me. And I was doing my best MI stuff. And you'd go in, get them a coffee, hang out. And then you'd convince them, hey, maybe he's not so bad. And they'd talk to me for a couple of minutes. And they'd agree to try stuff out.
Yeah. Well, I mean, that's, you know, I don't know. I mean, I never think you never think what you're doing yourself has got any kind of magical skill to it, but it's just a matter of putting someone that's, you know, been in similar shoes, not the same shoes because no one's journey is the same, but, you know, in the same room with somebody without the system being in there kind of thing, like kind of leveling the playing field, I think. And, you know, so that made my job a lot easier, right? You've got all the pressure of the stigma of an entire healthcare industry, you know, riding in your coat that you don't even wear, but if you wore the coat, right? And so it's hard for you to get that, right? But for me, I don't have the coat. And, you know, I don't have the, you know, kind of the credentials to be intimidating.
So when you went in there, you really saw yourself as an advocate for the patient.
100%.
I'm going to make sure that they get the best care possible. I'm going to understand what they're going through, and I'm going to help the medical team serve them better.
Yeah. I mean, in a lot of ways, I saw myself as a bit of a navigator / translator. You know, where I could speak, you know, I could speak the language of the person laying in the bed to the people that were, you know, sitting at the table, right, and vice versa, right, where I could communicate where, okay, you know, this is not really as it may seem, you know, it's
they're not against you, or maybe they are against you, but
the ones that are, we'll call it out, you know, and I'm going to be transparent about that, but find a way to work with those forces and try to find a way to help them navigate a way that's going to get them better care. But most importantly is the thing that you talked into your intro there is to keep them in care, right?
Yeah.
And not necessarily even get them better care, but do whatever we need to do to get them to stick around, because we know when they leave, they come back, they either don't come back or they come back much sicker. And then the outcomes become much worse. You
know, it's interesting because I think about, you know, when I get a phone call, I get a page, I get a consult, what do I think about? I think about what do I need to do in my assessment? What are the treatment recommendations? How do I keep them in hospital? How do I convince the team? But I think I was missing that advocacy piece, you know, where I wasn't explicit in my mind around, this is someone that may have been harmed by the system before. This is somebody that may have difficulty with trust. Let me just really figure out what they need first, and then all the other stuff I'll sort out later. And part of me wonders, had I had that philosophy from the get-go, maybe I would have been able to do better care before you joined us.
But I think if you know you're too hard on yourself in that. I think because we've worked on the same team together, you're the best advocate I've ever seen for a patient. Right?
Oh, dude,
you might do it. You might do it. You might not think it's advocacy, but that's exactly what you're doing, right?
Oh, okay.
At a much higher level, because you're trying to bring everybody along with you, right? You're trying to bring the building along with you, the nurses along with you, the you know the patients that the physicians that you are like you're in as we're as in a consulting service, so we're not in charge of the patient's beds. They are. So you need to advocate to them to say, okay, you know, I get it. This guy's a little bit difficult to deal with, but you know, have you thought about what he's been through? Have you thought about, you know, maybe if we do this, maybe if we do that, and you're the guy saying, maybe we can get him a TV, maybe we can get him this, maybe we can get him that. So.
Thank you. No, that's really, really kind of you to say, and I appreciate that. I don't always see the value sometimes in what I provide in those contexts. so you're there as a part of the team with us, and then this ECHO opportunity comes around. And you may have noticed I'm cheating a little bit, right? Because I'm saying, oh, we're including someone with lived experience on our team. But we pulled you in because you were a peer support worker, right?
Yes.
So you already have that dual role, right? Where you might have had lived experience in the past, but you're sort of functioning as an extension of the team. And because you were an employee at the hospital, we could just find a way to put the funding in to cover some of your back pay. And we just had to get protected time for you to join. And so even though I say it was someone with lived experience, it was someone with lived experience, but who's also a part of our clinical team.
Yes.
What was it like to be invited? Do you have any idea what you're getting into? I mean, you're at a bunch of these meetings, you're like sitting there. I mean, you're very professional and polite, but like...
I had no idea what it was.
What it was?
Like, what is this ECHO thing? And we're sitting in a room and there's some cameras going on.
Yeah, a lot of
there.
cameras. This is before Zoom was cool, right? Now we all know what Zoom is.
Yeah. So we were the pre-Zoom, definitely the pre-COVID, pre-Zoom, pre-everything.
Yeah, we liked Zoom before it was cool.
Yeah,
we were
exactly,
hanging out with Zoom all the time.
And, I had no idea. I had no experience, speaking to in front of people, certainly on this subject.
Interesting.
Now, in a previous life, I in business, I did have a career beyond substance use and helping people with substance use prior to that. So I did have some experience at a completely different level in a completely different context, speaking to people. So, but that was something that had been pretty dormant in my life for 15 years at that point, because, my lived experience kind of, really held me down. Right. And, in a lot of ways, and this ECHO was a real something of an opportunity for me because, every other opportunity that I'd had from being the patient to now working in a hospital and I had a number of jobs in between there too, in the same, kind of stepping stones of this, but you always kind of felt like they had, it's probably a horrible expression, but you felt they had training wheels on them, right? You felt like you were, being coddled or, they didn't really know what to do with you in a lot of cases.
Oh, you mean as a peer in the hospital?
As a peer in the hospital, and every other job up to that. I mean,
you mean like when you were starting? When you're starting,
yeah. Well, yeah, and that's when I was starting, right? So that's what I knew, and but this ECHO and the CAMH St. Mike's partnership, the Unity partnership at that point, there wasn't any of those training wheels there, and it was just expected. I was just expected to say something that was somewhat entertaining or somewhat not entertaining, but informative or useful. And there was no one there to hold my hand to do it. There was no one there to write the words I was going to say. It was just on me, right?
Yeah.
And it was sink or swim time, right? So
Well, it's interesting how you looked at it that way, right? I just maybe because I've worked beside you, and so that I know anytime that you give recommendations or advice or suggestions or like, hey, what's going on here? Like it's always added to our understanding of it, And so from my end, I mean, this is going to sound weird. When talking about patient care, I've not seen you come up with something that was so out there that I'm like, everything that you've said has always made me sort of expand my approach a little bit and also involves calling out, right, on some of these things we do in healthcare that aren't always in the patient's best interest.
Yeah. I mean, it's, well, thanks for saying that, but it didn't, at the time.
It didn't feel like that back then.
You don't know what you're looking for. You don't know what.
Oh, you don't know what we wanted.
You didn't know what you wanted.
You didn't know what we wanted because
No.
we had we had social worker to psychiatrist. We had some operations manager. Back then we had the manager who's now the head of the telemedicine stuff that's there. We had a social worker. We had a nurse. Yeah, you're right. So in terms of professional designations,
No, so there were kind of this was. I'd met you before this. We'd worked together a little bit, but I mean, this was our primary vehicle where we'd worked together intensely, right? At this point, and it was.
Oh, I didn't even realize that.
It
You're
was
right.
You and the co-medical lead, Nitin Chopra.
Oh, you're right. Because I think you'd only been with us for a few months.
Yes, that's correct.
And I just I pulled you in. I was just like, yo, we need you. We want you. Da 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 da.
You didn't have a lot of other choices at the time, I don't think.
Yeah, I just.
But
because I wanted
so
somebody
lucky.
who had a past history of injection drug use on that committee because I felt all of healthcare. I mean, more so back then. It's a little bit better now. Weren't sure what to do with patients who injected drugs.
Right. Yeah, and we're still not, and we're still struggling with that, right? We still struggle, but this is what the beauty of the ECHO is, right? So this is the whole beauty is kind of getting this knowledge of addiction medicine from the ivory towers, if you want to call them that. They're hardly ivory, but getting it from there to these decentralized points, to these smaller centers, using your New Mexico model, getting it to North Bay, getting it to Thunder Bay, getting it to Sault Ste. Marie, right? And this is, there's a lot of people didn't even know, addiction medicine, what addiction medicine even is.
Absolutely, yeah. They didn't know about the medication options. They didn't know the different strategies to engage. They may know what motivational interviewing was in terms of words. When you ask what they do, they're not using those techniques. And definitely the harm reduction world, right? Because back 100%. Then it was shocking to say, oh, you have someone with an addiction. Oh, they're coming to hospital. Give them a bunch of drugs so they don't leave, right? Because that was around the time that we were trying to deprescribe, right? Like take away those drugs. One interesting thing happened early on, and I don't know if you remember this. I don't know if it was like the first session, the 10th session, what it was. You somehow took on the role of our host. You were the first person that would talk. You're the last person that talked. You'd guide the conversation. You'd nudge us, hey, talking too long, talking too little. And in retrospect, I loved it, right? Because we have someone with who identifies, because a lot of people have lived experience. Not everyone identifies as it. And so someone who identifies as having lived experience, and you were the first person that they saw, you were the last person that they saw, and any time that you would share your opinion, you could see in the audience's eyes, because that was before people did black screen Zoom. We'd have to have sessions where, like, please turn your screen on. You saw it in their eyes that they were impacted by what you were saying.
Well, I mean, and this is kind of the growth, right? So this is the growth that happened, and I don't know where it was, whether it was the 10th session or the 20th session or whatever it was, but it was a slow growth, but it was kind of like an awakening inside of me, right? Where it was like I can't.
I belong here. Yeah, I'm doing a good job.
And it was an awakening that I hadn't lost what I had before, right? And that's something that I thought was lost forever. And it was so powerful to start being able, because in my last job, I was able to command a room of 50 people and they would be interested in what I would say. But for 15 years and 10 years of very intense drug life, I thought it was completely gone, that I'd never be able to communicate at that level again. So this was me finding my voice again, and it was so powerful and so transformative to my life. And I can't, I wouldn't be sitting here today if it wasn't for that echo. We wouldn't be talking in this room. I guarantee that.
It's a podcast that's on YouTube forever.
There you go.
Right. So back then you didn't believe you had something to offer. So even though I believed that there was so much that I was getting out of every conversation with you, you didn't believe you had stuff to offer.
I thought most of the time where I was ever in a room, there was such an element of tokenism to it.
Really?
And but in a good way. I didn't say it was a bad thing, but that's what I thought.
That's what it felt like. It felt like tokenism.
It felt only because I didn't have the confidence what I was saying was of any value. Not because the people hiring me did that. But it just felt like, I'm not adding anything to this conversation.
It's interesting. Like we can go through this down the road. There's this whole literature, especially it's very common in healthcare, very common in high achievers, around this imposter syndrome. And I'm not sure if it's like 50 to 70%. It depends on which population you look at. But what you're describing is actually very, very common. I mean, that's also why I love those things like the Brené Brown stuff, or is it Amy Cuddy, those TED Talks where they're like, fake it till you become it, fake it till you make it, all that stuff. But I went through this education program at Unity a while back, and that was one of the sessions that they had. So what you're describing is actually very common among academics. It's very common among physicians. They're just so used to it that they just like keep it inside and you don't see it on the outside. Well, sort of like, because I didn't know that you felt that way. I'm like, here I've got a colleague, and now I can't wait to hear what he says. JP, what do you have to offer? And here I am. He's going to knock it out of the park, and you always did. But for you, that was a high-stakes situation.
Well, sure. You're in a room full of people that are, that have been doing this for their whole life, and that are, are physicians, are registered professionals of one sort or another. And, you wonder okay, well, what do I have to add that they don't know? And, and it's something, you always struggle with, I think, in a certain way. I mean, in a lot of ways, I guess, as my confidence has obviously gone up, or I wouldn't be sitting here. But, then I actually, and ultimately over the years, it went from that to, hey, I've got a lot to offer. And, because I've sat in that bed, I've been that person you're trying to approach. I'm not like every person, not every journey is the same, but I know my journey, and even I not only know my journey, I know a lot of other people's journey that I've supported over the years now. So I don't feel that way anymore. I feel that I have a perspective that should be listened to. In fact, if you guys really want to get this right, you better listen to it, right?
Yeah.
Because it's, I'm speaking for the person that's not in this room, not exclusively and not with their permission necessarily, but, I've been there.
Yeah. At what point did you feel like the role of the introduction, the host, the facilitator? At what point did you feel comfortable? Was it a constant process?
I mean, I think we got there. I think it was sort of like my colleagues were just amazing. Every colleague that I had, whether it was a Unity colleague or and there's been so many and mostly CAMH colleagues, but I mean they were all great. I mean, without exception, they're just some wonderful, wonderful people. I can't say enough good things about ECHO at every level, from the administrators to beyond. But I don't think anybody wanted the job. Maybe that's one way of saying it. Nobody wanted to be the kind of master of ceremonies, if you will. So I think I just sort of, took it on and, it was something that spoke to me, and I have that that kind of ability to do it.
Yeah, the other thing that comes up, and the reason I asked you about the work life before was because there's so much parallels with the ECHO, right, around really taking on that advocacy role. Although I didn't know that's why I was asking it earlier. And one thing that really came out, every block we would have these curriculum sessions where we decide what each session was. And anytime there was something around, say, harm reduction, safer supply, which is taken off in Ontario in terms of accessibility compared to where it was, say, 5-7 years ago, and other things, you were very adamant. Sometimes like, oh, we don't know, they haven't published papers, they haven't done this yet. So the question I was asking you, JP, had to do with our education sessions, right?
Yes.
So we would always have planning meetings, post meetings, all that stuff where we try to figure out what the curriculum was. And there was a couple of times you brought up stuff that was evidence-based, that was important, also stuff that was more on the cutting edge, right, of what addiction care could be. And you wouldn't let us dismiss it. Like, I don't know, we were scared to talk about safer supply, or some of us were, and you're like, look, this is happening. This is part of it. This is the way. This is before they had all those centers in Toronto that were offering it.
Yeah.
And this is like 3-4 years ago where the guidelines hadn't been published. They didn't have their publication in CMAJ yet. Can you talk a bit about what it was like to be that advocate at the education table around we have to have this dialogue?
Yeah, well, I mean, I think, listen, I mean, we put ourselves out there, and rightfully so, as kind of being the tip of the sword of knowledge, really, in this field.
Oh, we said we're the place to go. That's what we were saying.
Well, I mean, that's we are, and we were, and it continues to be. But if you're going to do that, then you can't just
ignore it.
You can't ignore the tip of the tip
and
see where it's headed, because you guys
Absolutely.
can see it's happening here, and you can't stick your heads in the sand because you don't want to take a position on something sometimes, right? Because it's not, as we know, it's controversial, right? All this stuff is controversial, and it's easier not to say stuff, and I'm not immune to that. But but you can still put the knowledge out there without necessarily getting into the whole controversy of it, and say this is what's happening, and this is what's happening. This is where it's happening, and this is the evidence, or this is not the evidence, but this is what it's based on, and that's what we do, right? We present that, and
absolutely.
we're not telling them what to prescribe, and we're not telling. It's not like the stuff that is really proven, things like Suboxone, right? I remember you was so impassioned trying to get people to test their first script, right? It was always
nobody did.
They did. They did. Sure, they did, right? Okay. And it's like, and then yes, they definitely did, right? And they would say, I wrote my first script, and you'd be like, yay, your first Suboxone script, right? Because we know when they write one, they're going to write two, they're going to write three, and then you got them.
Once you've seen the lives saved, you can't unsee it. You can't unsee it, right? Once you see that the impact that it has to give the best addiction treatment and what it does to their life, you can't unsee it.
Yeah, absolutely. So it worked, and so that's so I think we have to put that knowledge out there, and I think we have to continue to do that. It's not meaning we're saying we should do this or you should do this. We're not telling them how to run their practices.
Yeah, no, and I hope there's a way that either you continue to be involved, or whatever education committee I'm on, there's someone like you there, because you need people that call you on stuff, right? Because there's a lot of things where there's cutting edge stuff that ends up being life-saving, And can we really afford to wait till a paper comes out on it, right? So now the people are doing a lot of macrodosing with buprenorphine. There was the microdosing a while back, there was also the practice of giving high dose opiates so people don't leave hospital against medical advice. A lot of these things have been published in small case reports, case series, all sort of throughout, but they're not common knowledge, right? And they're not commonplace, but they're sprinkled there in the literature as well. And so I hope that in any committee that I'm on, there's someone like you there to really push for those things as well. So far we've shared the role of the advocate, right, around that peer support, what it was like to be in that environment, almost that imposter syndrome that you had when you started, and then also that excelling kind of thing that you did as sort of the host / facilitator. And for me, metaphorically, just having you as the face of an education module for me was very powerful. I also wanted to ask you about what it was like, because whenever we did a harm reduction talk, you started with your story, and you may not remember, or maybe you do. I remember looking at people's eyes, and I know my own eyes, and there was like tears almost every single time, because it was such a powerful transformation, right, in terms of what happened. One was the devastation that you faced early on, but that recovery story, bam, to come from where you were. And I'm just wondering what that was like, because for me, I feel nervous about putting that story out there. I'd be like, is it tokenism? Then I start to wonder, hey, do they only want me for my story? Is that why I'm here? And it obviously, I say, hey, JP, we don't want you for your story. Just do a normal talk on harm reduction. And every time it'd come in, you'd have your own story, and you'd share some other element that of like, oh my God, I can't believe he went through that, And I felt so bad for the past you.
Yeah.
And I felt so impressed and amazed. I don't know if I'm allowed to feel proud, but I feel so excited by where you are. What was it like to put together these talks, these didactic PowerPoint talks, trying to capture something that's...
Well, that's, the challenge of everyone with lived experience is to sort of, kind of navigate, their comfort zone and what they share. And if that's something that helps them. So I'd like to think that it's helped me by sharing my story. And I think as time's gone on, that recovery story, it keeps getting better, right? It keeps getting better. Like if you look at it from year to year to year, I don't want to forget where I've been. And if sharing where I have been, it's not really sharing, but see, that's the point. If you're focusing on where I've been, it's not, but it isn't that. It's where I've been, and then look where I went.
Yeah.
And that's the whole part of sharing my story, because especially for every healthcare worker that I've ever spoken to that sort of writes people off, right? And I'm not immune
writes
to
people
this.
off. What do you mean?
Patient off, saying, you know what, you have been here 12
times. People are writing patients off.
Of course, they're writing patients off. We all get frustrated from time to time and saying,
we feel like we've done everything. We've done everything we can.
Everything we can.
They'll change when they're ready. We've done what we can. Okay, I get it.
And this is,
I get it. We hit that tipping point.
I'm not going to deal with you again.
Yep.
And but for every one of those encounters, it's so good to see. I think it's powerful to see somebody that has come back from that, not only come back to the point where they're, kind of a member of society, but they're a colleague of yours now, right? They work in a hospital, right? They got a badge. They work here. And
you got a badge.
They pay
you're running an ECHO. You're running a session.
They pay taxes.
There's
they're a full member of society, right?
Yeah.
They've had less sick days than you have this year, and that's so it's like that kind of sets their understanding on its ear. Because in that case, it's like, okay, so when I'm looking at that next guy who's, I'm sorry, it's telling them to go F themselves, and that happens. It happens every day. It's not necessarily, it's not their best day, right? It's not that patient's best day. In fact, it's one of their worst days. And keep that in context. And, because that person, may, if there's the right set of circumstances, may be able to pull it together, right? And and even if they're not, of course, I'm not saying to treat people poorly, obviously, but I think it humanizes it, and I think that's the important part. So if sharing my story puts me, makes me a little vulnerable, okay, maybe it does, and maybe it keeps me in that loop a little bit longer, but I'm willing to do that. so that we can get change some minds, right, and open some eyes.
Yeah, the other part of what you used to do when you were presenting, and I don't know if this was done intentionally or not, your story would evolve over time, right? And the way it would evolve, I found that a lot of times it would depend on who the audience was we were speaking to. And so you would share a little bit of the suffering, which I think is important, right? Because, you want to be able to evoke compassion for those patients they're seeing. That whole idea that you said around, like, you have a colleague and they've been through the same thing the patient has. So a little bit of that compassion around the hardship, but then you'd almost like embed these teaching points in there, right? And so sometimes you talk more about the TCAT training where you learn to be a peer support worker. Sometimes you talk about the micro moment with the social worker that helped you sort of shift. Sometimes you talk about the injection in hospital to help them have compassion to coach on how to provide harm reduction skills. It was almost like you thought about your audience and what you wanted that impact. Like, what were the impactful things? So telling the story was partially about you, maybe, but every time I was listening, I was hearing all these embedded teaching points that were directly relevant to which audience, because we've taught residents on this, we've taught caseworkers, we've done these at different environments, right? Our harm reduction talks.
Yeah, I
like, was it intentional or did it just evolve?
Well, it was intentional. That it's over time. Isn't it funny that some of these challenges, where right now I've got the honor of being on a few policy committees at my current employer, where we're talking about how to navigate injection in a hospital. Well, I'm a guy that injected in an ICU every time I was there. So isn't that funny that now it's come full circle? That,
they probably want to know, how'd you do it?
Well, how did I do it, right? And how can we support the people? They're doing it now. I didn't invent it. I can tell you that. It didn't start with me. And it didn't stop with me. But now you've got someone at the table that actually did it. And how do we support that person? And how do we keep all our staff safe? And, because there are all kinds of challenges, right?
Yeah, I mean, the last thing you want is a needle stick injury with the staff, right?
Absolutely. So when you have staff that say, okay, no needle dispensing bins in the hospital, I'm like, okay, that's fine. You can do that. But let me tell you what happens when you don't do that is that after somebody injects, they're going to have to put that needle somewhere. They might be a little bit paranoid and they're probably high.
In the bed seats or something.
And they're going to find a spot. They may not even remember the spot. I didn't remember the spot, so that's a reality that we need to deal with. But I'm so lucky, and I hope my employer feels that they're lucky too to have someone at the table that knows what that looked like, right? Because I was the guy. I was that guy.
Yeah. A couple thoughts came to mind. I'll just share because they're sort of related. I really like what you said around seeing someone who's successful, and I think back when addiction practice wasn't so common, when colleagues or trainees would go through a rotation and they were there for a full month and they saw the person swearing and yelling at them, they got them through the withdrawal, they saw the person apologize, and then they saw the person in a group talking about how much they missed their family, wanted to heal and correct and all the regret, all of a sudden it shifted that as well. And we forget that with medications, sometimes the number needed to treat is like 8. So what does that mean? If we give somebody like a medication for their heart, only 1 in those 8 people will have less of a chance of a heart attack. And I think the work that you do in the hospital setting can help at least 1 in 8, if not more, right? Like, and so I think it's just so important to frame it that way. I feel it's been such a privilege, to see your journey. It's been such a privilege for you to share some of the stuff in the past that you've been through. And it's been inspiring to see your level of courage, right? Because you're a little bit like me where you're very sort of proud, you don't always share your deficiencies. I mean, I do, but sometimes it's a bit strategically. And for you to put yourself out there and the impact you've had has been really transformative. I see it in all this teaching stuff that we've done. We've talked about a bunch of things today. We talked about the ECHO and what makes it great, at least parts of it as well. We talked about your experience moving from someone with lived experience to a peer support worker to an educator. We talked about a couple of areas where you're really, really good at that, right? So in terms of hosting, facilitating the session, in terms of planning for the education thing, also being a voice at that table, right? Because if you're not going to fight for it, I mean, hopefully eventually I do too, but if you're not, who will? And then also how to package your story in a way that's actually educational and transformative. And you also shared the impact it had on you, right? And that, I don't want to say I've always believed in you, but I always, I believe in you, and it allowed you to believe in yourself again, right? Which is very, very powerful.
Yeah.
Is there anything else you wanted to say about the ECHO before we finish off for today?
I obviously I've drank the ECHO Kool-Aid, and everybody knows that. But I think that it's just it's an amazing program. It was well structured. It was well founded by yourself and Nitin Chopra, and brought on side. And if it wasn't, I have people that you guys have had my back the whole time through it, and that means a lot. And I've never felt more supported, more empowered. And it's, I can't understate how valuable it's been in my recovery. And, it's not just the ECHO, and it's not just that, because, people like yourself and, you've been my, one of my main kind of cheering sections for my entire recovery. So, you've never formally been, and we've never formally had any physician patient relation. Your support has meant more to me than any medical provider ever has in my whole life. So I think that's probably a good point to wrap it up on.
Yeah, no, thank you for sharing that. And I'm just going to sit and say thank you as opposed to whatever else I normally say. Thank you for this. And we hope all of you consider looking into the ECHO. And if you do look into the ECHO, consider including peers or people with lived experience as a part of the process. And for any of you that are doing educational projects for it, see if there's a way you can include people with lived experience at the program design, implementation, and the delivery. And JP, I hope all this stuff allows you to keep that courage and strength to stay involved, because everything I've seen you involved in, the final outcome is better than had you not been there.
All right.
Thank you.
Thank you.